Differential diagnosis, ectopic, fairly straightforward. Other causes of lower abdominal pain, so acute appendicitis, PID, torsion of the ovaries. Crohn's disease. Now, Crohn's disease can have quite an acute presentation, often in the lower right side of the abdomen because of the terminal ileum. And of course, femoral hernias in women can be quite small and difficult to spot, and they can of course present with lower abdominal pain. Okay, most of the issues about ectopics in the exam are going to be about diagnosis. First thing is that if you have a negative urine pregnancy test, effectively that excludes an ectopic. Now, people will debate that point, but they're so sensitive now that effectively it does exclude an ectopic pregnancy. If you suspect an ectopic sufficiently to think it's a real possibility, then you should in practice refer all such cases to gynecology. However, in low risk cases, the gynecologists may decide, and they may ask you to act on this, to monitor the patient's beta HCG level. So let's just talk about this for a moment. The human chorionic gonadotropin, so it comes from the chorion, and I'm just going to skip ahead a little bit to the next slide and just show you this curve here. So here's the full length of pregnancy from the beginning to delivery, and if we look at the earliest part of pregnancy here, here's beta HCG rising very quickly up to about somewhere between 8 and 11 weeks. It reaches a peak and then falls down again. And of course it's during this period here of the high upslope that you have the risk of an ectopic pregnancy. So if we take two tests of the beta HCG 48 hours apart and compare the later one with the earlier one, we can make some deductions. If it declines, if the beta HCG level has declined between the measurements more than 50%, then there's a miscarriage. If it's risen more than 63%, then it's an ongoing pregnancy. But between those two figures, then you have the possibility that it's an ectopic. So if it hasn't fallen below 50% and it hasn't risen above 63%, it could be an ectopic. So next steps in assessment, it would be an ultrasound, and an ultrasound really is only undertaken to look for an intrauterine pregnancy. It's an unreliable investigation to look for an ectopic. It's very hard to see an ectopic on ultrasound quite often because of bowel gas, etc. But it's much easier to see into the uterus. So if you've got a positive pregnancy test and there isn't an intrauterine pregnancy, then you don't know where the pregnancy is, and it could be an ectopic, or it could just be a very early pregnancy. But if you see a pregnancy within the uterus, then you know it isn't an ectopic. So that's the value of ultrasound, to see if there is an intrauterine pregnancy. If the patient has clinical features of an ectopic pregnancy and all of the investigations support it, then the gynecologists may choose to use medical treatment with single-dose methotrexate. Now this is outside our curriculum, we don't need to know this, but I think it's just worth being aware that these days with very early detection of ectopics, they can often be treated medically, which allows the tube to be preserved. But if that fails, then they're going to need to have surgical management, either laparoscopically or at open surgery. Just worth mentioning here that it's not unusual for questions about ectopic pregnancies to link on to major transfusion protocols. So you need to be aware of the whole process of dealing with massive transfusion for the exam. It can come up in the context of a GI hemorrhage, for example, varices, etc. And of course it can come up with ectopic pregnancies. I won't go to it in detail here. You need to be aware of your major transfusion protocol.